Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salamu ala Rasulillah. Thank you, Prof. Bishlawi, for this kind invitation, and thank you for the organizing committee for the organization of this meeting. And I had a hope to be with you physically in Cairo. Unfortunately, I am in the clinic right now, where I couldn't make it to be physically in Cairo. My mission today to talk about the clinical spectrum of sickle cell anemia. And as you are aware, sickle cell anemia has progressed over year, and since it has been described by James Herrick 100 years ago, people kept working on sickle cell anemia, starting from the penicillin prophylaxis, hydroxyurea trials, stop trials, twitch, switch, and so on. So the lifespan of sickle cell anemia patient compared to the other or normal population, they are picking up, and it is improving over years. The spectrum of clinical presentation of sickle cell anemia, it's really a spectrum. Start from those patients whom we do see them in the clinic and they never need admission, never need to come to emergency room, to those patients whom may present with multi-organ failure, passing through acute chest syndrome, nephropathies, and so on. This is a simple method that you can remember the complication of sickle cell anemia and crisis. HBSS being crisis, and you can name them, or you do the way you like for memorizing the complications. Dactylitis is one of the first complication or presentation of sickle cell anemia, and usually they will present during the first or the second year of life with the hand and foot swelling, pain, and so on. And maybe this is the first presentation where you can do the diagnosis of sickle cell anemia with. Painful crisis. Almost all sickle cell anemia patients, they experience a painful crisis at least once during the year, even mild one where they don't need to come to the hospital. But it is very common, and most of the admission of sickle cell anemia to the hospital usually due to painful crisis. You have to take the history, physical examination, lab test, and we categorize the management into home management, ER management, and inpatient management. At home, family, they can do some sort, or the patient themselves taking more fluid, take paracetamol, non-steroidal anti-inflammatory, cognitive measure like distractions, if a child or adult, to do something they would like to love to do it. So we distract them from the pain by itself, massage or physical therapy or so on. So it may reduce or even treat the pain totally. In emergency room, of course, when the pain cannot be controlled at home, they need to come to the emergency room, where we will continue IV fluid, non-steroidal, and we may start those patients on something more strong like morphia or so. So those patients with morphia, we can give the morphine immediately within 30 minutes from their arrival, and we can do 3 doses at emergency room, and then if the pain elevated, can discharge the patient. Otherwise, we need to admit them to the inpatient ward, where we need to monitor those patients. If there is any diagnostic test, we know, like whenever there is low oxygen saturation, you need to do chest X-ray. Of course, you will do CBC, and we need to give them IV fluid at least 1 or 1.5 maintenance, unless you are expecting acute chest syndrome where you need to give 2 tier. Morphine, there is many forms or many ways to deliver morphine to the patient. Either boluses, where most of us we are using, continuous infusion, and the best one, it is BCA. Now, when we calculate the morphine for those patients, we escalate the dose according to the pain feeling by the patient, where we can increase the dose gradually, and then taper it down gradually till the patient elevated. Don't forget to discharge the patient on non-steroidal anti-inflammatory. And this is the a pedigree for how we manage those patients and when to discharge this patient. And this is available in Ministry of Health Saudi Arabia. And it's a continuation about the doses and so on, where I'm quite sure that you know most of it more than me. Stroke. It is a catastrophe of the sickle cell anemia complication, where it is different from type to type, country to country. For example, in Brazil, they have reported 18% of their sickle cell anemia. They have stroke. In Medina, we have reported 10%, while our friends in the Eastern Province, they have reported as 1%. Don't forget that in Eastern Province, Saudi Arabia, they have Arab Indian sickle cell anemia. Silent infarction, unless you look for it by MRI, you may not found it. Be aware that second stroke after the first stroke, it happened in the 70% of the patient within 3 years. Usually the stroke happened during the childhood and usually within the 5 to 15 years. And of course, in the elder age group. During the early ages, the infarctive stroke is more common. During the adulthood, hemorrhagic stroke is more common. And again, during the age of 40s and plus, again, infarctive stroke come back again. This is a Kaplan-Meier showing the age at first stroke and sickle cell anemia according to the genotype. As you can see that SS sickle cell anemia patient, they have more rate of the stroke than, for example, S beta 0. You know, the transcranial Doppler and the STOP trial made late 90s, when they have started to practice the transcranial Doppler, the stroke came down in California to very, very low rate. And from there, we could get the transcranial Doppler to be part of our practice. And we know that whenever the velocity of transcranial Doppler, the flow rate, is high, the higher the rate of stroke. And we divide them into normal, which is below 170 centimeter per second, or 170 to 199, which we call it conditional, or more than 200, which is clear that the transcranial Doppler velocity is high. And we need to take an action for those patients. Those patients whom they have stroke, either frank stroke or silent stroke, they have some sort of school performance where they are lower than the others, language, memory, IQ, and so on. This is another study where they have looked into the IQ, where sickle cell patients, they have lower IQ compared to the normal people, and this is related to the vaso-occlusions for this stroke and so on in those patients. Nephropathy, another problem with sickle cell anemia, and most of the sickle cell anemia, almost half of them, they will have microalbuminuria, and almost 1/3 of them, they have frank proteinuria. A few of them, they may go into end-stage renal failure and they need transplantation. As you are aware from the nephron anatomy and pathophysiology and the acidity and oxygenation and osmolality, it is different for the different part of the kidney. And sickle cell anemia, they are sickle cell RBCs are sensitive to deoxygenation, acidity, higher osmolality, where they go into sickling. That is why nephropathy happen more commonly in those patients. So they may manifest into glomerular ischemia, proteinuria, interstitial nephritis, end-stage renal failure, papillary necrosis, distal renal tubular acidosis, and so on. And probably most of nephropathies, it will happen during the adolescence and early adulthood. Sickle cell nephropathy, one of them rare complication with renal medullary carcinoma. It has been reported, though it is not so common among them. Hepatobiliary disease, another problem in sickle cell anemia, starting with cholelithiasis, gallstone, which is common among sickle cell anemia, passing through hepatic sequestration, though it is rare, but it may happen, acute ischemia, Budd-Chiari syndrome, hepatic infarction, and so on. So liver disorder, one of the problem in sickle cell anemia patients. Acute chest syndrome, the second most common crisis in sickle cell anemia. It's more common in pediatric than adult. It is the second cause of the pediatric admission to the hospital, and we define it as a new pulmonary infiltration on chest X-ray, plus minus 1 or 2 symptoms: fever, chest pain, hypoxemia, respiratory symptoms. It carries high mortality, like 25%, and the mortality is higher among the adult patient compared to the pediatric patient. So the acute chest syndrome cause more mortality in adult, and it is more common in pediatric. This is the commonest organism: chlamydia, mycoplasma, pneumococcal viruses, and so on. And they present usually with fever, tachypnea, cough, chest pain, shortness of breath, and so on. Of course, you cannot differentiate the symptoms of acute chest syndrome from the pneumonia, regular pneumonia we can see. In pediatric, we do not differentiate. We call it acute chest syndrome, whether it is painful crisis or it's infection, because infection leads to infarction, infarction leads to infection. As I said earlier on, mortality rate is high. The mean hospitalization stay usually about 10 days, particularly it is more severe in adults, and recurrent acute chest syndrome, it may lead or predict the severity of the sickle cell anemia in adults. This is the pattern where as acute chest syndrome more common in children, so it carried the same pattern of pneumonia, where it is more common during late autumn, winter, and spring. Pulmonary hypertension, one of the problems in sickle cell anemia, it is more common among the adult patient and defined as pulmonary artery systolic pressure, the mild one more than 35, the severe one more than 45, or tricuspid regurgitation velocity jet, again the mild for more than 2.5 and severe one more than 3.5. Pulmonary hypertension pathophysiology and the mechanism. There is multiple mechanism on pathophysiologies lead to pulmonary hypertension, starting from the chronic anemia, which lead to a pressure on the heart, left ventricular dysfunction lead to pulmonary hypertension. Recurrent chest infection lead to lung damage and pulmonary hypertension. Recurrent acute chest syndrome, decreased nitric oxide and bioavailability, and so on. This Kaplan-Meier showed the relationship with mortality. So those patients whom they have pulmonary hypertension, they carry a higher mortality rate than those patients whom they don't have pulmonary hypertension. Leg ulcer, another complication of sickle cell anemia, though it is not so common among all sickle cell anemia and all haplotypes of sickle cell anemia. It's more common among Arab Indian type of sickle cell anemia. And be aware that James Herrick, when he reported the first case of sickle cell anemia, it was a leg ulcer. As I said, it is more common among adults, more common among hemoglobin SS. In Jamaica, they have reported in 75% of their patients. In North America, they have reported in 10%. Exactly the exact mechanism still we are not aware totally about it, but it is mechanical obstruction, venous incompetence, bacterial infection, excessive vasoconstriction, anemia, thrombosis, and so on. And we divide it into 4 stages. It is like the Berne stages, where the stage 1 it is only erythema with intact skin, while the stage 4 full thickness of the skin has been lost with extensive destruction, and it may go deep to the bone. And again, this Kaplan-Meier shows survival, where those patients whom they have leg ulcer and recurrent leg ulcer, they carry a higher mortality rate among those patients. Avascular necrosis of a joint, it's not so common, but it is not uncommon. Most commonly, it is the hip joint, but may happen in the shoulder or any other joint. And that is why after the age of 10, we need to screen all patients with sickle cell anemia for avascular necrosis. And we look for that, and we take care about the symptoms whenever the patient carry a symptom about the walking and difficulty of walking. We need to think about it. Even for the shoulder, when they have a complaint about the shoulder, we need to think about it and look for it. Unless we look for it, the patient will present late, where there is nothing we can do. And many patients with avascular necrosis, they will end by a replacement of the joint. As I said, it is not common among all of them, but in some series, they have reported quarter of the patient whom they have avascular necrosis. The collapse of femoral head occur in 90% of the patient with 5 years of diagnosis. The prognostic factors, disease stage, lesion size by itself, the location of the avascular necrosis, presence of MER, and the radiological staging of the avascular necrosis. Priapism, one of the difficult issues among sickle cell patients, which is defined by persistent unwanted and usually painful erection. It happens in 30 to 40% of the sickle cell anemia, mostly during the adolescence time and early adulthood. And pathophysiology, again, it is a mechanical obstruction of the venous direction of corpora cavernosa, thrombosis, sickling process, and so on. Aplastic crisis. Another problem happened in sickle cell anemia, which is defined as severe type of anemia and reticulocytopenia, and usually recover early, and they may need the transfusion. It has been linked to parvovirus B19, and once it happens, it gives a long life immunity, but it is not the only cause of aplastic anemia. So even though it will happen again, so the second attack, it is common. Hemolytic crisis, it's some sort of anemia due to hemolysis of sickle RBCs. So in those patients, the difference from the aplastic, that the reticulocyte count will be increased in those patients, and both of them, of course, they need blood transfusion. Splenic sequestration, the disease of children, it happens in about 1/5 of our patients. It is sudden enlargement of the spleen and sudden drop of the hemoglobin. It is the second most common cause of death, particularly, as I said, in children, and usually it is happening during the first 3 years of life with high mortality and recurrence rate. That is why we keep those patients on transfusion to keep the hemoglobin is low till the age of 4 or 5, where we do splenectomy for those patients. Retinopathy, eye disease, hyphemia, color vision problems, it happens in many sickle cell anemia, and we need to check for it and screen for it every 2 years after the age of 10 years. It is very common to find retinopathy in those patients, which is a non-proliferative type of nephropathy or proliferative type. Caring of sickle cell anemia patient start from the diagnosis. Once you diagnose those patients, you start management. But actually, it should be start earlier on with neonatal screening. Those countries whom they have high rate of sickle cell anemia, they have to have a neonatal screening program where we start management at that time. And this is where how we can manage those patients. We have found that they have less infection, less hospitalization, less hospitalization rate for those patients whom we discover them early. But not only that, we start our care starting from the pregnancy. When we know that this lady has sickle cell anemia, we need to know that her child may be sickle cell anemia, even if she is carrier and her husband carrier, and we start even earlier than that. Preconception, we propose BGD for those ladies whom they are carrier for sickle cell anemia and their husband is carrier for sickle cell anemia. Premarital screening even before marriage happen. Education is very important among sickle cell anemia patients and families. Vaccination plan, penicillin prophylaxis and folic acid, and we have to have a follow-up roadmap so we know what to do at each visit of those patients. So hydroxyurea, one of the medication, anti-neoplastic medication discovered a long time ago, and has been used for sickle cell anemia over the last 40 years, and it has been shown effectiveness and safe medication among adult and pediatric, and it has been recommended for all sickle cell anemia patients starting from the age of 9, whatever the situation, I mean the clinical situation of those patients. Don't forget the new medication in sickle cell anemia, L-glutamine, Indari, and Voxelator, crizanlizumab. I don't have enough time to talk about all of these. Be aware that those patients with sickle cell anemia, they suffer of all of these problems, and we need to take care of them. The only therapeutic or curative way, it is the stem cell transplantation. And again, I don't have enough time to talk about it. There is a lot of guidelines to treat sickle cell anemia. And thank you for your listening. Ready to take your question. Thank you.